My name's Anthony. This presentation is drawn from a paper I'm working on, co-authored with my PhD supervisors, Bridget Hare, Christy Newman, and Martin Holt. I'd like to start by just acknowledging the traditional custodians of the lands where I live and work. I'm on unceded Bedegal country, and I acknowledge elders past and present, and also acknowledge any Aboriginal or Torres Strait Islander people who are here today. So I'll start by giving some key context about oral HIV pre-exposure prophylaxis, or PrEP. It refers to combination antiretroviral drugs prescribed to people who are HIV negative, so that don't have the virus. And it's a pill, and if taken on a daily or an episodic basis, it effectively prevents the acquisition of HIV. In Australia, PrEP has primarily been targeted for use by gay, bisexual, and other men who have sex with men, reflecting Australia's localised HIV epidemic. And in New South Wales, PrEP was rapidly scaled up and rolled out through a demonstration trial setting, enrolling nearly 10,000 participants between 2016 and 2018. Broad availability of PrEP resulted in a reduction in recently acquired HIV by 40% in New South Wales. Rapid declines in HIV notifications not observed for over 2 decades. From 2018, PrEP was listed on the Pharmaceutical Benefit Scheme, enabling broad access through prescription from general practitioners, sexual health clinicians, and other prescribers. So this has been a massive period of change that should not be understated. For example, PrEP has overtaken condoms as the most commonly used HIV prevention strategy amongst gay and bisexual men in Australia, changing meanings of what constitutes safe sex. The transformative effects of PrEP on sexual practices and cultures have been well documented in the social sciences, both locally and abroad. But given that clinicians are a necessary part of putting PrEP into practice, because PrEP requires a prescription from a clinician, how has PrEP shaped their clinical practices? There have been minimal social science studies of PrEP providers, including documenting how PrEP transforms clinical cultures and practice. One exception is the work of Nichols and Rosengarten, who interviewed clinicians working in London. They argued that PrEP introduces a difference to the clinical encounter, shifting expectations for the clinician in how risk and responsibility are discussed, and enabling a different style of clinical practice based on realistic discussions about sexual practice. Stepping back from the specificities of PrEP, social scientists have argued that while new technologies and medicines offer the potential for a better life, they can also produce new and unintended consequences, solve or compound existing problems, but regardless of their effects or consequences, they constitute new practices. Many aspects of clinical practice are highly routinized and ritualized, and new medicines are both opportunities and threats to these routines, as well as to the professional identities of clinicians who are entangled in these practices. We know that uncertainty is a key experience or affect in adjusting to prescribing and implementing new medicines. But beyond uncertainty, how are new interventions felt and valued by clinicians? The following question guided our analysis for this paper. How has PrEP transformed HIV prevention, and how do clinicians think and feel about these changes? We've drawn on some different approaches to affect in order to frame our analysis, including the following considerations. How do feelings move and circulate between bodies and collectives? What mobilizes and attracts people? How do memories and repetition shape the present? And how do these considerations shape affective practices? How is the present shaped and governed through orientations towards unknown futures? And what matters to clinicians and why? What kinds of relationships of care are built up and sustained through clinical practices? As part of this, we were also interested in the specificities of the sexual health consultation, and Cook's work on the moral work of sexual health consultations is interesting. She argues that clinicians act as moral educators, including when taking a non-judgmental approach, because the taking of a non-judgmental approach is itself a moral position. So this paper is drawn from my doctoral study, PrEP in Practice. And for this study, I conducted 28 semi-structured interviews with PrEP providers in Australia between 2019 and 2020. This was an exploratory qualitative study with the aim of examining a broad range of perspectives about providing PrEP, speaking to both public health or clinical priorities as well as the social aspects of prescribing. Participants included 12 general practitioners, 9 sexual health nurses, and 7 sexual health physicians who worked in either New South Wales or Western Australia. And we inductively developed 3 themes through a reflexive thematic analysis with a focus on affect. So these are some of the themes that we've generated. And for this presentation, I'll present some findings from across these themes, but not necessarily drawing out the exact specificities of these themes. So in interviews, I asked participants to reflect on when they first began providing PrEP, which included many clinicians who were part of the initial demonstration trials in Australia. Participants described a range of feelings. There was a collective sense of uncertainty, optimism, and caution about PrEP. So this sexual health nurse reflected, when something new comes along, you have a level of anxiety and concern about it. So initially it was a little bit of, what's all this about? Interested curiosity, I'd say. Part of me was very optimistic. Is this something that's going to prevent HIV? A really good thing? But how is it all going to work? Beyond initial periods of uncertainty, participants reflected that they became increasingly confident with prescribing through experience, but also the widespread collective success of PrEP and the relatively minimal or easily managed drug side effects. So they were anticipating that there would be lots of side effects as far as kidney function, for example, and actually much of it didn't play out, and it was quite easy to prescribe in many circumstances. So when I asked participants about their present context and future of prescribing, PrEP was often figured as a site of excitement, energy, and optimism. This sexual health nurse beamed. It's been really exciting to be involved with PrEP. I think it's fantastic, and I hope it's available to everyone who needs it. But of course, adjusting to PrEP required a personal and professional reconfiguration of values about sexual health and HIV prevention practice, as illustrated through these next 2 accounts from sexual health physicians. The first reflected, I remember thinking to myself maybe 5 years ago, after hearing about the PrEP trial, the general feeling was, oh God, I don't think I'd ever take that myself. Or it just feels quite shocking to me. And I think it was one of my friends when I started PrEP, they said, I can't believe you're choosing that lifestyle for yourself. And now that seems so backwards. And this other clinician explained, we were worried about sexually transmissible infections or STIs. And now suddenly we're telling people, you can take these pills and yes, use condoms. But you know everyone's not going to use condoms now that they're on PrEP. That took a bit of shifting. So between these 2 quotes, there are a range of different feelings and values being contested regarding priorities in sexual health, but also moral ideas about acceptable sexual practice. These particularly reflect the implications of PrEP disrupting cultures of condom use amongst gay and bisexual men. And of course, condoms had been the central strategy which there was so much invested in. But it's important to note that condom use had been declining prior to the introduction of PrEP. So it's not necessarily that PrEP completely disrupted that, it was already changing. So the role of condoms were gradually reconfigured through the increasing normalization of PrEP, opening up new feelings towards discussions of condoms, risk, and condomless sex. As participants adjusted to the logic of PrEP, it enabled some to admit long-standing faults with condoms in the context of the sexual health consultation. For example, this general practitioner reflected on condoms, explaining, you feel like you're nagging them about using condoms. In the heat of the moment, I doubt they're going to be thinking about what their GP told them. They're going to do what they feel like doing. So you'd always talk to people about using condoms, but there was a sense of futility about how effective that messaging actually was. Consequently, clinicians felt that PrEP permitted them to engage with patients in a different way. This sexual health nurse explained, we've been trying to tell people to use condoms for decades, and that doesn't work, and people don't use them. And now we've got something that we can say to people, look, it's okay if you're having lots of condomless sex. We're happy that you're honest with us. And if you're not going to be using them going forward, there's all these things you can do. Across these 2 quotes, we can see how feelings and values about condoms and HIV prevention are generated through interactions with patients. So the feelings are moving between the bodies, but also through a shared vision of what the HIV and the sexual health sector is trying to collectively achieve. Because PrEP is effective if taken, consultations with patients using PrEP became simplified, removing the need for a comprehensive discussion of HIV risk or to nag patients about using condoms. Both patient and provider were less anxious or concerned about the testing process because a potential HIV diagnosis was not at all expected if the patient was using PrEP. This sexual health nurse explained how it created a different world. They said, "A lot of the conversations I used to have, I don't have as much anymore. It's funny, like we've created a very different world in sexual health now with PrEP because we're not doing as much pre-counsel around so many things because clients are on PrEP. It's changed the way that I practice, like they're taking their PrEP, they're taking it all the time. The consult goes for 5 minutes because you're like, any concerns, any issues? You know what you're doing, off you go." And yet this simplification of the consultation meant that a few participants felt some unease or trepidation, such as the potential that something was being missed. This sexual health physician explained, "It's easier because you know if they take PrEP, they're not going to get HIV. But I do worry about the psychosocial stuff that we miss out on. Like, I feel like it's all medicalized, which is all well and good, and the numbers show that HIV notifications seem to be decreasing. But I do worry that we might be missing out on something, like discussions around psychosocial aspects of why people take the risk that they take or why people have as many partners as they do. I wonder if we're missing diagnoses of anxiety and depression." This participant suggested that PrEP removed the need to explore the necessity to explore the kind of sexual practices and therefore the potential diagnoses that might come from that discussion. And this sense of loss is interesting because it reveals particular assumptions about how risk and sexual practice relate to mental health, but also shows how clinicians become invested in particular routines and perhaps taking a surveillance role, which might be disrupted by a new medicine. Indeed, the effectiveness of PrEP might mean that asking patients about their sexual history is now largely redundant, or perhaps it always was to some extent. While PrEP was primarily constituted as exciting, there were a range of conflicted feelings and values across the sample about PrEP. For example, this sexual health physician complained that PrEP has created a rather sort of boring landscape for sexual health clinicians. Our time is taken up testing and having the same conversations. And that's a problem because the time that we spend dishing out PrEP is time that we don't get to do other things. But far from this suggestion of boredom or resentment towards differing priorities in service provision, this other clinician suggested that PrEP was an opportunity to feel very differently about their work. They said, "I haven't thought about this before, but I feel a bit less useless now because I've got more to offer the patients that I see in terms of preventing HIV. PrEP is not for everyone, but it's revolutionized HIV prevention for a huge number of the patients that I see." So what does this all mean? We think it's important to attend not only to how new interventions change expectations and practices, but also how these changes are felt and valued by clinicians. It's important to consider how affect is suffused through clinical practice. PrEP has clearly introduced a difference to the clinical encounter, as Nichols and Rosengarten also have observed. In our study, this difference was reflected particularly in how condoms, condomless sex, and risk were discussed and managed, but also in the routines of the sexual health consultation, which were often figured as easier. New drug prescribing can be a site of uncertainty, but also caution, excitement, shock, discomfort, and unease. And paying attention to these feelings and what these feelings do can reveal priorities for what matters in clinical practice. In the case of PrEP, it's often an enjoyable and easy medicine to prescribe because it involves providing an intervention that many patients actively want and ask for, and that works to prevent HIV. And so that sense of what the patients want and what the clinicians imagine them as wanting is something we've taken up in one of our other papers that's published. So I've finished there. I just want to thank all the clinicians that took time to participate in the study, the members of the study projects advisory panel, and acknowledge my funding sources there, which is just my university. Thank you.
Thank you, Anthony. You've given us so much to think with, and I was really struck by the reflexivity of the medical practitioners And yeah, they're really nuanced, rich responses. I think often we assume medical, or we cast medical practitioners in quite a one-dimensional light, and it was really your presentation showcased their reflexive, considered responses. So thank you for that.
Yeah, and I should say, so I worked in a sexual health clinic and was part of experiencing those transformations while also being a gay man and experiencing PrEP as this kind of exciting object. So I think I really appreciate that it was a challenging prospect for the sector, and it was challenging particularly for clinicians who are then kind of tasked with having to meet the demand.
Yeah, absolutely. And yeah, juggling those challenges. I think that Nicholas might have had a question, which he flagged offline.
Yes.
Sorry to put you on the spot, Nicholas.
You did. I was going to say, Gemma. No, I was thinking about there's been this massive shift with prescribing around PrEP, which has reduced HIV infection rates. But at the same time, there's an increasing moral panic around antimicrobial resistant gonorrhea, kind of syphilis infections. And so how did that kind of shape the clinicians' kind of experience of prescribing practices, the conversations they would have with people, and I guess the sort of moral, I don't know, well, the sort of framing of the advice that they would give?
Yeah, absolutely. So that kind of the dilemma around the condoms versus STIs versus PrEP is something we've looked at. So Martin, who's here, has published a piece in the Sociology of Health and Illness, which takes up some of that, and it continues on. That was from a previous study of stakeholders, including some clinicians, and it continues on in my study of clinicians. I think so obviously they don't need to worry about condoms anymore for HIV, and it actually doesn't matter if your patient is using condoms, but then they're like, oh, but what about STIs? And there's a few different positions that people seem to take. So sometimes they take this kind of pragmatic position, which is sort of like, well, at least they're getting tested all the time, and the HIV is being prevented, and that's the most important thing. But then the other kind of perspective is, well, we never asked people to use condoms for oral sex, well, not in the last few decades anyway. And that's actually where a lot of STIs happen, and potentially where the antimicrobial resistance sort of happens, although the antimicrobial resistance also happens heterosexually and from like migratory transmission as well. So sometimes that moral panic is focused on gay men in particular, and doesn't necessarily, I think there's more of a focus on gay men because they're so overstudied in terms of sexual health. So that's where all the focus is.
Thank you.
Thanks so much, Anthony. Gemma, did you have a question? Your hand has disappeared. Otherwise, I think we have one in the chat.
Hey, how's it going? I do have one. I feel like you've kind of been answering it already, Anthony, but I'm just curious to hear. I suppose what I found really interesting about your presentation is this discussion of risk and how risk is being kind of constituted and reconstituted through these different technologies like condoms or with PrEP. And I suppose I wanted to ask if you'd be interested in speaking a bit more about how PrEP like uniquely constitute or like enacts this kind of risk as a mode of governance, because I imagine that, these bodies are still being constituted in relation to risk, and how is PrEP doing that uniquely?
So, I mean, yeah, the whole risk thing has been reformulated, because at first, people needed to be high risk to get onto the PrEP trials. And then there was clinician discretion, so then you could kind of tick a box or whatever and get onto the trials. And then they sort of change, and then there's this whole literature in the sector, particularly from the US, around how, getting people to frame themselves as risky is actually really stigmatizing, and because of the kind of stigma associated with you know, it's a whole confessional thing of having to go into the clinic and, you know, tell the clinician that, you know, you've been having bareback or condomless sex, and therefore you need to go on PrEP. And people often don't want to think of themselves that way. They might practice it, but they're not going to think of themselves as that kind of subject. So the guidelines have changed to emphasize suitability, and it kind of pretty much means that if you ask for PrEP, the clinician's supposed to prescribe it to you regardless of any risk profile. And that's something we explore a little bit in terms of anxiety, for example, because even if you don't explain any risk, the fact that you've asked for PrEP creates perhaps a sense that there's some undisclosed risk, and so therefore the clinician should absolutely prescribe regardless of whatever practices you share. So I don't know if that quite answers your question, but there's been a changing relationship with risk just in that short period of time.
Yeah, really interesting. Thank you.
Thank you, Anthony. And I'm conscious there are people saying things in the chat, so I would encourage you, if you still have some energy, to have a look before we close at the chat. And thank you for your engagement there. I'm sorry, Eduardo, I'm going to call it at this point, just because I am conscious that it's been a really long afternoon and you've all been incredibly engaged and attentive. And I know that is no mean feat on Zoom land. So big thanks to you all and to my fellow co-conveners and presenters today. It's been an absolute pleasure hosting you. We wish we could have met in person, but we're very grateful for your attention online and your patience with us.